Good evening, everyone. Welcome to this evening's meeting of the Health and Social Care Scrutiny Review Group. Just a reminder about all the admin stuff. So anyone in the hall, if you can set your phones to mute. Remote participants using Teams, can you use the hands up icon for questions and comments? Turn your camera and microphone on when speaking and off when finished. Members in the participants in the hall, if you could make sure that your microphone's turned on when you wish to speak. This is a meeting in public, and it will be live streamed to the public, and a recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. Okay. Any apologies for absence?
Apologies from Councillor Fatima Begum.
Okay, we go on to the minutes of the last meeting. Has anyone got any comments or questions or points they want to raise on the minutes? If not, I'm happy that they are a fair record of the proceedings of the last meeting. There's the only thing I would mention is that although we don't actually assign actions during the meeting, there are a number of points and actions that have been taken on by various people, and I will try and follow up with those individuals to see if those issues have been followed up. We've gone to any disclosures of interest?
None, Chair.
Urgent business?
Again, none, Chair.
References from committees or other bodies?
None, Chair.
Okay. Agenda item 6, my update. Nothing. The only thing I have to report on is the progress of the joint overview scrutiny committee on the Mount Vernon Cancer Centre relocation. We had the first meeting before Christmas to formally start that process, and that process will continue on. We have the next meeting of that committee is on the 5th of February. If anyone wants any more details about that process, I'll be happy to update them. Okay, if we go on to the first item, the first report this evening, the update on the Bedford Emergency Operations Centre. I believe, it's Neil?
Indeed, yes. Neil Maloney, Chief Executive of the Ambulance Service.
And could you introduce your colleagues as well, please?
Oh, do you just want to introduce yourself?
Mark Stanbridge, Head of Clinical Operations for Bedfordshire and Luton.
Good evening, I'm Simon King. I'm the head of the control room at Bedford.
Thank you. Yeah, if you'd like to go ahead.
Yeah, thank you. And really appreciate you inviting us along this evening to talk to you a bit about the Bedford Emergency Operations Centre, or EOC. I think there has been a significant amount of concern that's been raised by, I think, staff and from local residents about the impact that the potential closure of the Emergency Operations Centre at Bedford. As you can see from the report that I have submitted in advance of the committee, there has been no decisions that have been made about this yet. And I can understand there has been some speculation that I think may have given rise to individual members of staff raising those concerns. But I should explain that I have been in post now about 4 months, and this was an issue that came to me about 2 weeks after I was in post, and I was very clear that there had been neither no decision at our trust board about the potential closure of the Emergency Operations Centre, or indeed any reports through to the trust board that would warrant any concern from staff. However, since the report, since the staff had raised those concerns, we have had a report through to our board that has been looking at some of the criteria that we would need to consider about the number of emergency operations centres that we ought to have within the region. And there's some good reasons for that, because certainly at least 2 of those emergency operations centres don't meet modern standards. And it's right for us to consider what is the appropriate number of emergency operations centres so that we can plan appropriately in the future. We've given a very clear commitment to our staff that we would engage them at a very early stage, and I have been doing that, and that undoubtedly has given rise to some initial concern. But I think they've certainly appreciated the involvement in those conversations, because I know that in involving them in those decisions, we know that we can, or at least in involving them in the criteria or the development of those criteria, will enable the board to make those more informed and better decisions. Now, I should point out at this stage that the board is expecting a report back either in February or March that will essentially identify how many of those emergency operations centres that we require. We currently have 3 operating in Norwich, in Chelmsford and in Bedford. And we will make a decision about how many emergency operations centres that we should have in place. Once that is complete, assuming that there is any change to that, again, we will ensure that we are involving not only ourselves but other stakeholders in some of the criteria that will enable us to make the decision on which of those emergency operations centres will see any change. And if, as I've mentioned already, that we are going to need to do some work on each of those emergency operations centres that are currently not meeting the requirements, is the extent to which we're going to be able to achieve that. And of course, that will inevitably require some further engagement and consultation, not only with our staff, but also with our stakeholders, and I'm committed to doing that. That's probably as much as I perhaps need to say at this point, but I'm very happy to take any questions on that.
Okay, thank you. Does anyone have any questions or comments? The Chowdhury.
Just comment. Thank you for your report, for your update, and I'm sure you're going to keep us updated in terms of what changes come in the future as well.
Yeah, we're very much committed to doing that. I think it's really important that we involve our stakeholders in this discussion. I mean, one of the important factors in this that I think is really important, because I think there has been some information within the press, for example, that's highlighted the importance of at least having a local understanding of the services. And I should point out that these are emergency operations centres. You could put this anywhere across the whole of the region. It doesn't require a detailed understanding of the local community in order for you to be able to receive a call and understand whether that patient needs an ambulance or not. But there are some important considerations in this, and we recognise that this will have a number of people that are employed within this region. So we're committed to ensuring that we're engaging with partners through this process.
Okay, anyone else? Councillor Mead, then Councillor Latif.
Thank you, Chair. What's prompted this? Has there been some sort of a failing somewhere being noted, and you've decided that you need to reorganise, or what? Can you tell us, please?
So a really good question. In my time in the trust, many people have talked to me about this ongoing question about how many emergency operations centres that we need within the organisation. And frankly, that's been going on since the ambulance services first merged, going back to 2006. Most ambulance services, I should hasten to add, generally speaking, have no more than 2 emergency operations centres that serve the needs of all of their residents. And so there is something for us to determine how many we actually need to have in place. What I would say is that when we have reviewed whether, for example, some of the opportunities around expanding those emergency operations centres, expect the question about, well, if we're going to do that, we need to ensure that they meet modern standards. We know that our activity continues to grow, and there are some particular limitations that we have both on the Chelmsford site and also on the Bedford site that would mean that we would have to invest in those sites in order to make them viable. So to ensure that our staff are able to to operate out of those environments. Now, there are some particular concerns that we have on both of those sites, and we would need to address that. And we're committed to considering that as part of this process. But the first step, I think, is to determine how many we actually need. So how many of those sites are we going to need to invest in, or are we going to be looking at an alternative arrangement that enables us to best meet those the needs of our patients in the most cost-effective way?
Atif?
Thank you, Chair. I think Clive's answered most of the question I was going to ask, but thank you for coming tonight and thank you for the report. I just want to say, obviously, the news that broke about a month ago that Bedford Centre was going to close did upset a lot of residents. So perhaps the trust could put up, because clearly you had no plans to close it. It was misinformation. Do we know what happened? How we got to a place where a lot of residents and a lot of members were concerned with the closure of the Bedford operations?
I can only speculate on that, and I suspect that I think because of some of the enhancements that were going to be required for some of those sites, that some individuals will have considered that that would mean, or immediately concluded that that would rule out Bedford EOC. I've been really clear with all staff throughout this process that as far as I'm concerned, there is no decision being made. And even if there is a decision that actually that site is not fit for purpose, it doesn't necessarily mean, given that there are also challenges on the Chelmsford site, that we would rule out an alternative site within the Bedford area. Okay, so those will be, I'm sure, should we get to a decision that it needs to be less than the 3 that we have at the moment, that we would look at alternative options and then look at those that are most viable for us in the future, because there will be some requirements on both of those sites.
Councillor Nessa?
Thank you, Chair. Yeah, if I'm wrong, just correct me, because last report when we did, it did show that the ambulance service is having, a challenging time because of it's been increasing calls every day and at night. And also, I think, as far as I remember, that the closure actually came because of the funding. So if we have had to close it, that will be a massive challenge for the ambulance service and the resident. So this is actually worrying, and we don't want that. Thank you.
Yeah, thanks for the question. So I'm really clear that our first priority will always be to ensuring that we're delivering the care that we need to provide to patients. Even if we were to reach a conclusion that it should reduce, we would not do that until we were absolutely assured that we had the sufficient capacity to meet the needs of all of our patients. So that will be our first priority. At the moment, we do have some challenges on our call pickup time, which is one of the key measures that we have for picking up the calls when patients ring in, and we are now recruiting in order to fill those vacancies. I mean, this is it's really important to highlight actually that in the call centre, this can be actually quite a traumatic environment for our staff, because all the way through the day they are responding to patients who will be in a very difficult situation themselves, or it will be a member of their family or friends that will be contacting the ambulance service. And so we do everything that we can to try and ensure that the environment that we're providing for our staff is a place in which that will look after their welfare. I mean, one of the challenges, for example, if I might just highlight, is that there's very little natural light within the Bedford emergency operations centres. And one of the things that we would be looking to do is to seek to address that as part of that modern standards that you might expect of an emergency operations centre. Okay, so hence the reason why we highlight that there will need to be some changes on both the Chelmsford site and the Bedford site, assuming that's possible. We do know that there are some particular limitations on the Bedford site that would prevent us from making those changes, and hence if we do conclude that there should be 3, we almost certainly would be looking at an alternative site for the Bedford area. But I mean, that needs to be taken into account when we look at, firstly, the first question is how many emergency operations centres do we need, and if there is a change, what are the criteria that would enable us to identify which are the best solutions and ensuring that even if we have identified those solutions, that we're involving our staff and our stakeholders and the understanding of the implications of those solutions, so that we go into that with a really clear, open, a very clear and open position when we're making that decision.
But what I'm understanding from you, that you say that whether these 3 stations, whether they are coping well, because it is, that's the question. And other thing is, I mean, the government is spending a lot of money on NHS. We know that it's going to be, so how we need to make sure that this, because of if the funding is not available, find a way to, how it's possible to look somewhere else for the funding.
Important question that you've raised again there. We know that a significant proportion of the funding that has been allocated to the NHS will be on specific areas. We haven't yet concluded the discussions that we'll need to have with our commissioners for next year, but I'm sure I have received information that is going to be another challenging year, and we will need to make some decisions about how we best utilise the funding that we have to ensure that we're best able to meet the needs of our patients. And this is one of those considerations in this case. We need to ensure that we are maximising our ability to be able to respond to patients, not only within the emergency operations centres, but also in our ability to be able to send ambulances out to patients, and making sure that we're maximising that capacity in all of the decisions that we are taking.
Just keep updating us so we know what's going on.
Do that.
Thanks.
Okay, thank you. I've got a few questions. We're talking about the number of sites that are needed, whether it's 3 sites or 2 sites. Can you? We're talking about Councillor Nasser was talking about capacity and performance. Could we clarify what the criteria would be in deciding whether we need 2 sites or 3 sites?
So I look, we haven't concluded that yet, and that we are due to bring back to the board in February and March. We are having some discussions with our staff and obviously with stakeholders. The 2 key criteria that undoubtedly will be included will be the requirement for resilience. So for that reason, it will almost certainly be more than 1. Because we need to ensure that if 1 site goes down, that we have the ability to be able to respond. But also, it's also about making sure that we're delivering the service most efficiently. And that will be clearly a requirement. But it's going to be more than that. And what we have committed to do is understanding our responsibility as an anchor institution. We're operating within those environments in Chelmsford, in Norwich, and also in Bedford. And we want to ensure that we are including that as part of our consideration in terms of our responsibility as an organisation operating across the whole of England, the east of England, in delivering those services in those patches. So that will be part of our consideration. Okay.
Talking about the geography, if it is 2 sites, so my understanding is from what you said earlier that it doesn't matter within the region where those 2 sites are. Is that correct? Because I think in the press reports that came out, then it was implied that if the Bedford site was closed, then that would have a detrimental impact on performance in this part of the region.
So it might perhaps be helpful if I was just to bring my colleague in, because we can perhaps just talk a little bit about how the emergency operations centres actually work and the reason why that isn't an issue in terms of call pickup and also the dispatch of ambulances.
Yeah, thank you, Neil. Good evening, everybody. So in an emergency operations centre, there are essentially 3 functions. There's the call answer, there's the dispatching of ambulances, and there's clinical advice for those patients that don't require a physical response. The call answer, to take that first, is a regional system. So wherever, if I were to phone 999 now, wherever the next available call handler is, whether they be in Bedford, Chelmsford or Norwich right now, would pick the call up and use exactly the same system wherever they are. And that's why Neil's saying that's already in place. The dispatching of ambulances. So the way that we operate ambulance dispatch is very similar to many other ambulance services. So there's a geographical based desk. So there'll be some desks for Bedfordshire and some for Hertfordshire and West Essex. They're generally an ICB configuration. But all of those people are required to have a working knowledge of the other desks and areas. So, for example, we talk about local knowledge. Should someone be a dispatcher who works in the Bedford EOC, then they'll need to be able to dispatch ambulances in Watford and Harlow and Hemel Hempstead and Luton, just the same as they will in North Bedfordshire. So that's already in place. The other thing is that we do have a dynamic response. So firstly, in terms of if we have a large scale incident, we will just almost seamlessly begin dispatching those resources from another of the control rooms if we need to. If there's ever a big incident in and around, I don't know, the airport or something like that, we obviously have plans in place, then we need a lot of resource in the Bedford room in the current configuration to deal with that. And so our day-to-day dispatching for ambulances in the rest of Bedfordshire may well go in that scenario to Bedford, to Norwich and Chelmsford. But also we have fluctuations in staff attendance, and if we find that on a particular shift that we've got better staffing in Chelmsford and Norwich, then again, it's a routine daily decision. We'll just move those desks to another room because the systems are all already regional and very much data based, and we can and should and can do that right now wherever they are. The other bit about the clinical advice, that is absolutely a regional service too, in very much the same way that call handling is. And lots of our clinical advisors, clinicians, they work on an agile basis from home. So we're utilising that technology that so many of us, you can see people on the screen now, so many of us became more familiar with during COVID. So that's already in place. So I think for those reasons, we completely understand why people would imagine that's how it works. And of course, people who work on the ambulances and the local managers, to a great extent, will have a great affinity with their local community. But in terms of centralised call handling dispatch, they really are regional functions. Hopefully that helps.
Yes, yeah, thank you. What was the I think you say that you are committed to good engagement with your staff. I mean, how is that process being managed?
So you can imagine when this first hit my desk, I personally have been out to talk to the staff in the Emergency Operations Centre on the Bedford site. I know that my executive colleagues have also been out there. Simon, who's one of the key managers in that area, has also been regularly engaging with staff throughout that process. In addition to that, in developing the specific criteria that we would need to consider, we've engaged with staff in a process to identify what those criteria should be, and also we will expand upon that should we reach a decision to make any changes. We'll again engage with staff so that we're really clear that we can identify some of the options that might be available in each of those areas, but also to really clearly understand the implications of those options. So I believe this is an ongoing process and a commitment that we've made to those staff to continue to engage there. I mean, look, what I would say is that can often give me a more challenging and difficult task, not least that we have seen some press interest in this, which I'm not surprised about, but that I would much rather that there was external scrutiny enabling me to have that discussion with staff, that I can get their input into and advice in ensuring that we can then make the best decision from this at a board level. So I think that's the appropriate thing to do. There is undoubtedly a level of concern out there because I think there are some staff that believe that there is a decision that has already been made. And I've been really clear all the way through the engagement process that there has been no decision. And I can assure you that that's the view of the board.
Okay, thank you. It's a little concerning that if the final decision is to go to two sites, then there is the potential for losing a number of highly qualified, highly skilled staff.
If there was a decision to move, we would obviously do everything that we can to seek to try and retain those staff and look for other solutions that would enable us to move those staff into other roles within the organisation. Although I accept that that may not be wholly possible for all of our staff, and of course we would also take that into account in deciding any options that we wish to pursue with, but both in terms of moving from from a position of 3 emergency operations centres, but also in identifying specific locations should we decide to proceed with any change.
Okay. So just to go back to the number of sites, if the decision is to go to 2 sites, is there any risk of reducing any margin for error? If I think Simon mentioned about major incidents. If there is a major incident, are you reducing the slack, the leeway that you have to deal with that major incident?
For all emergency operations centres, we do a huge amount of analysis every year about the number of staff that we're going to need to have in place, enabling us to be able to respond to that demand. I'm really clear. We need to ensure that whatever solution that we have in place, it will still enable us not only to be able to receive those calls, but importantly also to ensure that we're directing our staff to those major incidents.
Thank you. If there's any more questions, Councillor Ambier, then Councillor Mead.
Thank you, Chair. Thank you. We are going through the difficult time, like we had like lowest temperature since compared to last few years, and we are seeing on the news there was a new virus, and especially this NHS comes to the news every day, including ambulance service, their dispatch time and etc. So I'm worried about especially during the winter time. If you downsize your center, how are you going to cope with, especially on the winter time? Or do you have any strategy or any plan for this time of the year? You can have an additional resource or satellite hub to tackle the winter crisis or any sort of flu or any other cold-related issues during the this year. If you wanted to go ahead to 2 sites, is there anything option to open a satellite site to respond for short period of time? Thank you.
Thank you. Good. It's a good question actually, and you may be familiar with some of the press releases that we have been undertaking in the last few weeks. That this has been a truly unprecedented time. What we tend to see is then when we get increased activity and we get some of the challenges with our acute hospitals as well, that will increase the handover time at the acute hospitals, and that means that it takes more of our resource in looking after the patients whilst those patients are outside of the acute hospital, or indeed even sometimes in the acute hospitals themselves. Now I have to say, in this patch we have a very good level of performance relative to some of our other patches across the east of England, but nevertheless the issue is important, because when we get a greater level of delay, that does tend to mean that patients can be waiting longer for the resources, the ambulance, to arrive, and often that will mean that they are contacting us at this time of the year more than once. They will ring back again, and that can place quite a bit of pressure on the emergency operations centres. I'm afraid the answer to this question is quite complex, though, because in order for us to be able to address all of that, it does mean that we need to ensure that when we're looking at urgent and emergency care services, is that there is a good pathway of those patients all the way through into the hospital and then out into the community. Whilst you can see that there has been a relatively modest increase in the activity, actually the acuity of patients have been quite significant in those acute hospitals. And so, you know, there's a lot of lessons that we've learned from this year that we will make sure that we're ploughing into our discussion and debate about how we're going to manage this in next financial year. Mark, who's been doing quite a lot of work with our local colleagues, will be reflecting upon some of the services that we put in place this year that have enabled us to manage our some of those pressures. We are also looking at an independent review of our emergency operations centres. We're very keen to ensure that not only do we plan in the future to ensure that we've got the right number of staff to be able to manage that demand, but that we're also looking at other ways in which we may improve our productivity, and hence the reason why at the same time as that we're doing all of this, we're also looking to improve our productivity so that we can ensure that we're meeting the needs of our patients as we go into the future.
Yeah. So I have some.
Yep, sure.
Because you have seen is Luton is very density, and there are population is growing in the Bedfordshire area, especially Luton, Bedford. So I'm a bit concerned to reduce the capacity or reduce your service. How are you going to how public will get get a standard get the standard level service from NHS in terms of like dispatch and handover to the hospitals or paramedics to respond and like a minor injuries on site. So how are you going to cope with the demand and the growing population?
So again, I mean, I'll refer to my previous response on this, which I think, as Simon has highlighted, you know, we need to right size the number of staff that we have available in all of our emergency operations centres to be able to respond to those demands. As this is effectively a regional service, it doesn't matter in a sense where they're located, because there is, even though it's located in Bedfordshire at the moment, it actually takes on a role that not only delivers that service to the patients of Beds and Luton, but also to other areas. In fact, we were just mentioning that it's also Herts and West Essex as well. And, you know, irrespective of the number of these emergency operations centres, where we would expect them to be operating from would mean that they would still have to continue to provide that service across the whole of the region, and not just for the patch that they're currently in at the moment. But those are going to be important considerations when we start to look at not only the resilience that we had, as I mentioned earlier, ensuring that we're able to ensure that we can consistently meet the needs of our patients across the whole of the region, but also doing so in the most cost-effective way.
Councillor Mead.
Thank you, Chair. What's the timeline on this? When do you hope to have all this wrapped up by and everything in place?
Again, I have committed to staff that we are going to ensure that we have a process that enables us to get all of the information that we need and a level of engagement that enables us to make that decision. Now, I think everybody is concerned about this, and I think would like to see this concluded so that they effectively know. But I've also committed to ensuring that we're doing this properly. We have said that the first of those reports will come through to the board either in February or March. I don't think it will be later than that, which will determine the number of emergency operations centres that we require across the region. Should there be any change to that, that will initiate the next stage of that process, which is to engage widely on what some of those options that we ought to be considering, and that will enable us to work out what is effectively the most cost-effective option. There would need to be, on those individual sites, quite a significant amount of capital investment in order for them to be made to meet the modern standards, which we're committed to doing. All right, we know that there will need to be some investment in this, but we want to consider what is the appropriate and most cost-effective options, irrespective of whether it's 2 or 3. We're going to need to do that.
Thank you. I've just got one more question. You were speaking about the engagement with the staff, and considering what has happened in the lead up to this in the press and reports that have been in the press, how are you engaging with the public on this? Are you keeping the public in the region informed of what the plans are, what the process is?
In a sense, we're not talking about any significant change to the clinical service, but I am committed to ensuring that there is a consultation process, whichever decision that we reach. I mean, I think if we're not proposing any changes to that, we will just get on with looking at the proposals for how do we make those compliant area. However, if there are some changes, our ambition will be to ensure that we are talking to at least a group of people across our organisation, but also out into the community, so that we can be clear that there are solutions in place that best meet the needs not only of our patients, but also the staff that are going to be working in those areas.
And are you presumably you're talking with the various ICBs involved in this?
We will need to do that, indeed. Yeah,
Okay.
I mean, it's likely to be those that are most affected by any particular proposals.
Okay, if there's no more questions, thank you for coming here tonight and putting the trust side of the events. I think it's good to get some of these issues cleared up. Obviously, it would seem that you're only at the start of the process, so we would appreciate it if you came back with updates on decision making and on. I think we personally, I think it's the opinion of the committee as well that we would like a lot more detail on how you arrive at any decisions that that you potentially make. Okay, thank you very much. Oh, so just so to a different topic, just wondered if you'd like to comment on in the press recently. There's been a focus on the abuse that your staff have been receiving at the hands of the public. I don't know if you'd like to comment on that to the committee.
Yeah, you're very happy to do that. I mean, I think what has surprised us all, I think, is the scale of this. So, you know, across the whole of the NHS, there has been perhaps the highest level of violence and aggression that our staff has experienced since we've been collating the data, and we're on track. I think certainly after the first 6 months, we're anticipating, I think, just over 10,000 cases nationally, and that's predicted to then increase over this period, and we're looking at circa 20,000 by the time we get to the end of March, which is the full financial year. That's also consistent within the East of England Ambulance Service, and we've seen an 18% increase in those incidents, which is obviously very concerning. We do have a range of measures that are in place for our staff to be able to respond to that. We now are increasingly using body-worn cameras so that we can ensure that if there are any incidents of this, that we will tackle those. And I'm certainly very much committed to supporting our staff in taking them through the appropriate course of action.
Yeah, thank you very much. Thank you.
Thank you.
Okay. We move on to item number 8, addressing adult social care improvement work in light of addressing the budget deficit. Who is?
Jill.
Hi, Jill.
Hi, thank you. Thank you, Chair, and apologies to yourself and to the committee for not attending in person tonight, but we can probably hear I've got a virus, and I thought best not to pass that on to too many people. So I'll avoid public transport for a little while. So thank you for inviting me today to talk to you about how adult social care is still driving its improvement agenda in light of its budget pressures, which I'm sure colleagues will be aware of. The paper starts by giving a little bit of a background to those budget pressures, which I won't read out in full now, but obviously is there for your perusal. But the situation where we are at the moment for 24-25 budget monitoring at Q2. Appreciate we're just at the end of Q3 now, but further information has not been published. So we'll just take it from Q2, is a forecast overspend of 6.9 million. And that's despite an expected full delivery of a deficit recovery plan target of 2 million. So what that would have meant was if we hadn't been delivering that 2 million, we would be nearly 9 million forecast overspend by the end of the year. Now, some good and news on that is that seems to be slowing, but I don't have any further details at the moment for the Q3 position, but just to give you a bit of an indication. So you will see that this budget pressure is very, very real and significant, and we need to be careful, of course, in terms of how we spend our funds. But actually, just a couple of things to note. One is that we are not isolated in this situation, and many councils, adult social care departments are experiencing the same. And I attached as an appendix a report by ADAS, which is the Association of Directors of Adult Social Care organisation, and their financial advisors, setting out the state of adult social care across the nation. So you could read that for background and understand that whilst it is very significant and very concerning, and we're obviously doing a lot to try and manage that, many councils are in the same situation. And essentially, largely, it's driven by the costs, external cost environment, due to cost of living rises, energy prices, increases in minimum wage, etc., and inflation. So I'll move on to the main body of the report now, which talks about the improvements, which is part of our Strengthening Adult Social Care Improvement Plan, which has 6 work streams. So I've taken each one as outlined, and we'll talk about how that's advancing and how that should help us, if not now, but over the course of the next 12 months, actually improve our efficiency and potentially and our budget. So efficiency in staffing, but also in budgets. So the first element is the implementation of our new adult social care target operating model, which has been based on extensive analysis of our demand and processes. So this new model will mean that we will be able to support individuals earlier to prevent their needs escalating. But not all of that support will be delivered in terms of a costed care package. So it's very much a model that is used up and down the country, where we expect that we can help people to self-service, to look after themselves by giving them some advice and information, or some or basic equipment, or access to support in our voluntary and community sector services, local libraries, etc. And through the development of our new community hubs, which the council is working very hard on, we should be able to support people in ways that don't attract a huge care package. We already do this with our early intervention and prevention and enabling service, but we're wanting to accelerate this more and really support those individuals. And I think in previous meetings we've talked about kind of the role of the Luton Rising Grants Programme, which supports our voluntary sector organisations to do just this kind of work. So we just need to really work more closely together to enable that. And that will reduce then the number of people that go forward for a full care assessment, which will usually result in a cost of care package. So the second part of that, though, is 20% we would want to be doing target interventions and short-term work, which results in a review after 6 weeks to see if the care is still needed. So some people might need some crisis management. They might need to get back on their feet after a hospital discharge, an illness, perhaps a bereavement, or some other incident, but then be able to support to back to be able to look after themselves, which most people really would like to do. And then finally, the top part of the pyramid is that just 10% of people then who requests help from us would go into a long-term care and support package. So that's our intention. We will do that through a number of different ways, by improving our relationship with the voluntary community sector and our customer services teams, and also through improving our forms and processes to make things much more resident friendly, and also less kind of reactive and more proactive, and really listening to what people want, and also by reconfiguring at some points with our staff so that they're both based around locality teams and really know their local neighbourhoods and the resources and support that's out there. The second element is to improve our co-production with residents, both in designing their own care plans and strategically designing new services alongside us. And we know that where this is implemented, it actually delivers much more improved outcomes, because we are designing the services and shaping the services and really listen to our residents to make sure that we are meeting their needs in the way that they want them to be, which means that the services are more accessible and more fruitful and get much better outcomes. And we also know that that can really improve, that can really reduce our costs, because not wasting money on services that people don't get the outcomes that they need from, and then may need more care and support services. So we've got an example there where we've done that through co-producing our transport policy, which we brought to this committee about 12 months ago. But by doing that and really listening to how people wanted to travel and could get around, and what support they needed and how they wanted it delivered, we were able to deliver £200,000 cost saving. So a co-production framework is almost complete, and all adult social care staff are scheduled to undertake training. We're at about 50% of staff have completed that training now. We've also, in another stream, been looking at our performance, quality and complaints, and that is about really understanding our data and what's happening there, and really looking at the quality of the services that, the social work that is delivered, and the support that we give to our residents. So improving our performance data has brought greater clarity and insight into what's happening, and how we're benchmarking, and what we're doing well and what we're doing less well than in other areas, so that we can really target where we need to improve, and we can celebrate what we do well. Strengthening our quality framework for social work practice has improved the consistency and the frequency of our audit to drive up practice standards, encouraging a co-production and strength-based approach, and assuring adherence to the highest qualities of care. And this has been reflected in the number of complaints that we've received. In that our stage, in 23-24 compared to the previous year, we had about the same number of stage 1 complaints, but our response rate improved. So we were able to answer those complaints and resolve people's issues much more quickly and within and on time. And that meant that the number of stage 2 complaints that we got complaining about our complaints process or the outcome significantly fell, as did our referrals to the local government ombudsman. So that's really looking at those processes and improving staff quality is really making a difference. And obviously that makes a huge difference to people if they don't feel the need to complain any further and take that complaint up with other authorities. But also, of course, for us, that means that our staffing or time is being used to support residents and help support people's needs, rather than poring over paperwork and trying to resolve issues that should not have happened in the first place. We've also been working really carefully in the performance and looking at our number of people waiting for care and support. So during the last year, there was a significant reduction in the number of people waiting for social care or a carer's assessment, from approximately nearly 500 people waiting in spring 23 to 149 in spring 24. And the current figure is around about 100. That's waiting longer than 28 days. And we've also improved our performance rate, that we're now seeing about 50% of people within 28 days, as opposed to around 30% about 18 months ago. And that, of course, may be part and factor to our increase in care costs, because we've dealt with the backlog and maybe causing some of the pressure. But we also know that long term, providing care and support in a more timely way is likely to reduce the care costs, because you'll be able to, that people's health and care needs will not have deteriorated. And so we've got more opportunity to help residents regain their abilities and maximise their independence. We also have commissioning and partnership work taking place to improve our relationship with local providers. And we've established local provider forums now and arrangements with CQC Inspectorate for provider services, really looking at our policies, our processes, and driving up the quality of that work, including a revision of our annual uplift process, which last year ensured that the inflationary allowance built into the budget was more fairly distributed to provide a greater financial stability to the sector. And there was also significant attention to the manager of provider failure resulting from organisations misusing international sponsorship licence. So we've taken much more due diligence, which is really helping to stabilise our provider market and to avoid corrupt practice such as modern day slavery. One of the things that we really improved over the last year is also our shared lives offer, which is support and care for people, either in long term or for respite, where people are cared for in another family house, much like foster care for children. And we have increased the number of people accessing shared lives for respite from 2 to 8 people in the last 6 months. That might not sound a lot, but a lot of work goes into that, and it will make a significant impact into people's lives, and we want to continue that growth. We've also been improving our direct payments offer so that we can support people in the way that they want to, and they've got more choice and control over their care and support. So we do, Luton already does above the national average in terms of direct payment delivery. So we've got 27% of our care packages compared to a national average of 26%. However, we have ambitions to take this further and to do that more. So we're really working on developing a new direct payment advisory post and updating our procedures, as the feedback that we've had from our residents is that it can be quite clunky and there are some barriers. And if it was actually an easier process, then more people would take that up and feel like they were in control and managing their own care and support, for those that are able, of course, and their families. And finally, the 6th work stream is about the Care Quality Commission preparation. And we brought a paper to committee, I think just last month, on how we're updating and developing our work in relation to that. So I won't go into that particularly at the moment. But of course, driving that improvement will mean that if we avoid getting a significantly bad rating, which we very much hope that we're on course to, then, you know, we will not have to put lots of additional costs and resources into adult social care to drive up that, to drive up the quality and support. So in terms of our next steps, we will be developing all of those schemes that I've talked about and publishing our co-production framework. I won't read all of that out. I'm sure that you can all read that for yourselves, and I've very much touched on that as I've walked through the paper. But happy to take any questions and comments from committee members. I'm sorry, I'm losing my voice a bit.
Yeah, thank you, Jill. Does anyone have any questions or comments? Councillor Chowdhury.
Hi, Jill. Thank you for the report. You talked about performance data and which you were able to identify areas where you're doing really well and where areas where we're not doing so well. Can you just probably give us a few examples of areas you're not doing so well on, and which are the ones that we can celebrate?
Yes, of course. So areas that we're particularly good at is, as I mentioned, direct payment. Although we're looking at direct payments because we think we can do even better in that. But we are above the national average for direct payments. So that is one area, and we also have a relatively small number of older people who are cared for within residential care settings compared to other authorities. So they're a couple of responses. Where we're not doing so well, I would say, really in terms of residential care for working age adults is higher than we would expect it to be. So I think there's more that we can do there to support people living in, to be able to live in the community and not in institutional care. Of course, that's not really a simple answer, and you do need to kind of look at that more deeply. So we're undertaking actually developing from that performance work, really looking at some cost and demand work in the council and trying to get greater insight into that. So it's still a work in progress. So we've got the benchmarking figures and we can see where we're wanting to target things. I have to say the areas to celebrate don't necessarily jump off my head, so I'll have to practice that. But kind of really like another area is kind of improving our carers assessments. And so we've commissioned our support organisation Carer Centre to do some of the assessments for us on our behalf so that we can speed up access to assessments and identify more people. So we've obviously very much targeted our work on where we're not doing so well. So apologies, I'm struggling with my head cold to think of other examples where we are doing well, but we've definitely got some areas that we're really proud of, and particularly in relation to our learning disability offer, where we're, really above standards and things like annual health checks, and people really having lots of satisfaction in our services. Hope that helps.
Oh, thank you. And just a subsequent question. You said you've contracted out the care assessments. It raises a question. I mean, as demand is rising.
Sorry, it's the carers assessment.
The carers assessment. And just wondering, as demand is continually rising, do we have enough staff in place to actually deal with the demand that we're seeing?
Essentially, the reason that we've just to answer about the carers assessments, it won't be for all carers assessments, but we know that some carers, unpaid carers, don't necessarily want to have contact with the council, and that they and go through and wait for a formal social worker, and they'd be quite happy to work with a voluntary sector organisation that can provide them lots of information and advice and support groups, etc., for carers. But in Luton, we hadn't given that delegated authority to do formal carers assessments, which we have in many other areas. So that's why we've given that, so it can go hand in hand with the support and the outreach into the community that organisation will do for us as our partner organisation. So as soon as we think of it like that we're working in partnership with them rather than contracting out, because it's be very much hand in glove and working with us. Have we got enough capacity? Well, It's challenging times, I'm not going to lie, but I think what we are doing is really looking at how we improve our processes and look at our efficiency of using our staff resource. And currently, I don't think our staff resource is as efficient as it can be. So that's why we are, as part of our target operating model, looking at all of our internal processes and procedures and the forms that we fill in to do assessments and reviews, etc., which are in the process of being redesigned so that they'll be much more simple and intuitive to use and much better for our residents to input into and get their voice heard, as opposed to asking a lot of questions which are not always relevant to all individuals. So we're doing a lot on that side, which will mean that our assessments and reviews, etc., should be much more streamlined and simple and not create a lot of form filling for our social care staff to do after they've seen somebody. So it's in that way that I think that we will have the right staffing capacity to manage that demand.
Right, thank you.
Thank you. Actually, just to follow on from that, Jill, so just to make a comment that it seems to me that making cost savings and driving efficiencies is obviously the right approach, irrespective of any budgetary pressures or funding pressure. I think, and the sooner that we move to the more self-sustaining model of social care that you're talking about in this report, the better. I just have a few questions, and it's perhaps difficult to say, but do we expect the requests for adult social care to continue increasing at the same rate, or is there going to be a plateau in the next year or so?
Oh, well, that is that is a difficult question to answer. What I would think is that as we develop things, like I'm sure that you've had conversations with Mark and colleagues about the development of community hubs and more kind of joining up of our voluntary sector organisation into community spaces and making all of those offers much more accessible. I would hope, and alongside our health colleagues in developing our neighbourhood health and care services, I would hope that people start to realise there's lots of help and support out there for them, and they don't always need to formally come to the council in order to ask for that. So that way, that's how we're trying to manage those number of requests that come forward, and that was what we would like to see by how we would reduce those. So currently, the requests for support have been massively increasing, as I've described, about 10% a year, but actually that doesn't necessarily translate into all of those people needing support. And so we need to do much more downstream for people to see that there's access for help and things without having to come to social care and the council formally, and how we can really help that. Because I think at the moment we don't make that very easy for people, and that we can improve that by our, as I said, our community hub development and our integrated health and care networks that are neighbourhoods that are establishing themselves. And that is part of the reason why my teams in social care will be restructured into facing into those localities and neighbourhoods, so that they can really work alongside those colleagues, and we can really promote all of that self-service model and access to all kinds of different support, and connect people into their local communities, which we know really helps to sustain people's well-being and health.
Okay, so all this work that you're talking about, moving towards a sustainable model of adult social care and working with local communities. So obviously, if it is sustainable, then that's going to have an effect on future budgetary requirements. In the meantime, is there a threat to this work that you're doing from the the pressures of the budget and from funding pressures?
No, there's not an immediate threat, I wouldn't say, because a lot of the things that we're doing are, as I say, as I described, kind of like improving the quality and the strategic way that we work. I think there's more where the budget is being spent is actually on those care packages for people. So I think that's where we need to, I don't think we would be stopping this kind of improvement model that we're talking about, because we know that that will help in the long, in the medium to long term, and that has got the full support of the Director of Finance. What we need to be doing is challenging, making sure that we're right sizing our care packages, and that we're also having how should I put it, having a closer partnership and commission arrangements with providers to make sure that we're getting the best value for money, and that we're only putting services in place that are proportionate to the needs that people have, and not over providing institutional care, for example, which is very costly, when we could be working with health and care and voluntary sector organisations and community care provision to support people in their own homes. So it's really about trying to upend that and think about how we strategically work and reshape things. So I don't think it would. The budget pressures are now not stopping the work that we're doing, because they don't come. It doesn't cost us hundreds of thousands of pounds to implement these things. It's more that it will deliver efficiencies and better outcomes as we move forward.
Okay. Oh yes, we're talking about the community hubs. I think you've already touched upon this, but how is that progressing with adult social care?
So it's oh, sorry. Was there anything at the end there? Sorry.
So go ahead.
Okay, we're doing that thing where we're both talking over each other. So it's progressing really well. I think that there's a number of hubs that are getting set up and organised, and there's very detailed work across with our social justice colleagues and the voluntary sector, alongside our customer and customer services and how we interface that. And we're starting to, a number of our adult social care colleagues work alongside the voluntary sector already, so they're involved in that and starting to see how they can interface with that. So everything is coming together quite well, and we're thinking about how we can put housing advisors within there. I don't have the full details, so I'm not directly on that transformation programme, but it is progressing well. And I'm sure that they would be more than happy to come and talk to you about it. But I don't have a perfect update on that, but we are working closely, I think, to make sure that as we move into the hubs, that we are going to be alongside them as they become fully operationalised, which will be, I've actually got a meeting next week to talk about when that will be.
Okay, thank you. Just got one more question. So I appreciate you having difficulty talking, but could you give us some more information about the shared lives project? 'Cause I'm not sure that was something that I was particularly familiar with before this evening.
Yes, absolutely. So, as I say, if colleagues are familiar with a foster care model for children, it's a very similar type of model, in that families and individuals can come forward and volunteer to become shared lives carers. And what that means is, following obviously an assessment and approval and training of those shared lives colleagues, that they take somebody into their own home after a very careful matching, and that person lives in their home and supports them as they would a family member. And for some individuals, that's long-term support, so they might live with them permanently in that way rather than them having institutional care, perhaps after their family carers have passed away or are too elderly to be able to do that care now, and they prefer that family environment. And what we've been working on, particularly in the last 12 months, is expanding that offer for short-term care. So when families and carers need a break from caring from their loved one, so that they can go and stay with a family that they know for a weekend or a few nights or a week or so, on a fairly regular basis, maybe, I don't know, it would depend on the family, maybe 6 times a year, maybe twice a year, to give that family a break, but know that their loved one is being cared for in a family environment with people that they know, which can often help them adapt to that more easily than going into short-term institutional care if they need that 24-hour support, and really can help people as well kind of keep their skills in terms of those people that are able to go into the community, etc. Then they can continue to do that and build on their experiences. And we've got some great examples of an individual, I think, he was a younger man, so maybe only in his late 40s, 50s, but really couldn't look after himself because of a range of different challenges, and would have been in a residential care if we hadn't found a shared lives place for him. But we managed to find a shared lives family that was acceptable, and he had some sensory needs and things like that as well, and they supported him to be able to learn his lived environment outside of the home and to be able to go about his life, and has really settled in and is living a much more fuller life. So it's that kind of model, much like, as I say, foster care, only it's for adults who have got needs, social care needs.
Okay, thank you. Does anyone else have any questions or comments? Councillor Chowdhury?
Jill, just on the Shared Lives project, is like foster care, is there a financial benefit for the family who's providing the accommodation for someone who needs care?
Yes, there is a financial benefit. I can't tell you how much it is off the top of my head, I'm afraid. It's very bad of me, but I can find out. But there is a financial incentive, just like there is for foster care, because obviously you will have additional expenses, another mouth to feed, extra heating, etc. So yes, there is a financial benefit.
Similarly, if you could provide information on the respite as well, because I don't think it's very well advertised out in the community about Shared Lives. I don't know if it's already running.
It is already running, but it's a very small number of people. So at the moment, we are recruiting additional Shared Lives carers and training those. So we've just run a big advertising campaign on our local buses to get additional carers so that we can grow that service. So there's currently, in terms of the Shared Lives respite service, at the beginning of the year, that was just supporting 2 people with respite. But we're now supporting 8, so it is starting to grow. And as I say, we've got a big recruitment campaign happening at the moment, and we're also looking at how we could support people in more emergency times as opposed to planned respite, and thinking about how we might be able to support people in the future from hospital discharge for a short time before maybe they're well enough to go back and live alone. But those bits are early days, so it's very much a development project that we are growing. And it would be individual social workers at the moment that would recommend that type of respite, rather than us saying we've got this right now, because it's just not big enough to be able to do that, if you understand what I mean.
Okay, anyone else? Okay, Councillor Ambia?
Thank you, Chair. On the page 24, you have mentioned younger adult care package has increased by 10%. My question is there, do you have any plan like to, do like periodical medical, to send them on a medical assessment for rehabilitations, or to like to make like to improve their like mental and health, mental and physical condition to come out from the care service, or do you work with any other GPs and other external agencies to improve their well-being for the younger people?
Yeah,
Thank you.
Yeah, what this paper means by younger adult means any adult between the age of 18, which I'm sure we'll all agree is younger, and 64. So it just means people not of that 65 plus. So just to clarify that. And I think just so we have a number of what we tend to describe them in Luton as working age adults, so those between 18 and 64. The majority of younger people or working age adults who use adult social care services have got some kind of significant disability. So that would be a very serious mental illness, perhaps that has led them to have quite a long hospital stay, or they would do if we weren't putting that support in. And people with learning disabilities and physical, long-term physical disabilities, perhaps that they'd the younger of the working age that they may have had from childhood. And of course, then as you get, towards the older age of the working age, they might have some physical health conditions like a stroke, etc. Excuse me. Excuse me a second. So all of those individuals will have healthcare support from their GP and often from specialist care services as well. So they will all be receiving those, and we would absolutely be encouraging people to seek that support and to get well where they can. And a number of those individuals will be able to get well and move on with their lives, get better, and also we would provide short-term social care support for those individuals. But we do have a lot of people who've got disabilities that will always mean that they will need care and support needs. So it's a bit of a mixture.
Thank you. Good.
Okay, thank you. Anyone else? Okay, so we're asked to note the progress made in adult social care despite budget pressures and the continual commitment to continue to drive the improvement agenda, which will support cost avoidance and reductions for the council, which I think we can do. So thank you very much, Jill.
Thank you. Thanks very much.
Thank you. Okay, we move on to the item number 9, the work programme, draft work programme 24-25. So we need to approve the work programme, and we need to determine whether there are any items from the Executive Forward Plan or the Health and Wellbeing Board that need including. If I haven't seen anything in either of those two groups that we need to include at the moment, does anyone else have any comments on the work programme? Okay, thank you very much. I think we can then conclude tonight's meeting. Thank you, everyone.